Hi,
Hi, Daniela. How are you?
I'm good. How are you?
Good. It's nice to see you.
Yes,
You
likewise.
you
How's
look
summer?
great. Like your
Thank
hair
you.
is like
I know
lighter.
it's gigantic right now.
I love it.
Uh,
Well, it looks
how's,
like we have two prospective students on.
oh, that's awesome.
So that's good. And we have like 20 people registered.
That's great. That's awesome.
Yeah, Michelle can't make it on today, but I'll plan to take attendance and I'll probably just let you run it,
That's fine.
and stay a little bit more low key and do more administrative stuff.
Yeah, that's totally fine.
Um, yeah. I'm
Cool.
sure more folks will wander in, but thank you so much, as always.
Yeah, of course.
You guys survived the storm.
Yeah. Yeah. Luckily yesterday it like stormed out pretty early by us, but then that was it. And then I was actually surprised my sister-in-law lost power, but like way after the storms at like 9 o'clock last night. So she
Oh,
came over.
really?
Yeah, it was very strange. So she came over and dropped off a bunch of her groceries, but luckily her power came back on at midnight. So that was good.
I know some of the students said their power was out. It was really like wild here for a little bit, like just so dark.
Yeah, yeah. I
And
was
then,
like, it looked like, again, not the correct time of day. I was like, oh, okay. I wonder if all day it'll be this dark.
right? Yeah, it was like, it feels like it's like 9 o'clock and it's noon.
Right. So I'm like, tricky. But yeah, luckily it wasn't too bad out by us. So yeah. What about you guys? How are you guys enjoying the summer? Are you guys are in the midst of summer semester?
Yeah,
You're
we
almost
actually
done.
had our final, like our client educator evaluation session. It was,
Oh, exciting.
yeah, if you remember that promote process. Today. So we were like just in the final stretch wrapping up and then yeah, getting ready for orientation and all the
Yay.
things fall
That's
semester. It
exciting.
all
I
happens
know.
so quick.
It's creeping upon. Yeah. I was like, I think I have maybe 2 more weeks until I go back to work. And I'm like, no, but summer just started.
Oh, really? Have you had quite a bit of flexibility this summer? Or...
Yeah, so I did summer school for like a majority of June, so that was only like half days, few hours. I got to work with the older kids, which I really liked. So I'm like maybe in the
Oh, that's
future that's
nice.
what I'll do. Yeah, so it was a good little change up from working with like the little ones. And then I actually just got back from Bolivia
Oh,
Saturday, no
really?
Friday. Yeah, I went to go visit my grandfather again with my husband and my sister, and it was awesome. I love it. It's such a different way of life. I really enjoy it.
Yeah. Oh, just a little change of pace. And I see Annika that joined. I didn't want to bother you with this, Annika. That is so nice of you to
Oh,
be here.
absolutely. Hi. Hi, sorry, I included you on the email because I was like, just in case. I don't know if Annika wants to
No, I
come, but I
appreciate
enjoy
it. Thank
Annika,
you.
so
Yeah, thank you, Annika. Thank you, Daniela.
yeah. One quick thing, Bridget,
Yeah. It's
share,
here. Brigid's here.
can you allow the sharing of
Yeah.
like screens? Because I know a few of them have created either little slides or PowerPoints. Hi, y'all.
Hi.
Hello, Anna. Hello, Bridget.
Hi. Okay, and we're waiting for Sierra. I'll just make sure to keep an eye on her chat.
Beautiful.
And then I'll work on screen sharing as well.
Okay, perfect. I'll just give you guys a little bit of a rundown. I'm Daniela. I'm the one who's been sending you emails. So thank you so much for joining us. Yeah, the Q&As are actually pretty casual, I would say. It's actually a really nice opportunity to connect with not only prospective students, but some current students too, and for them to get to ask you some general questions. And typically, the way I'll start it out is I'll introduce myself. I'll give a little bit of a background of like how these started and why they started. Then I'll turn it over to you guys to introduce yourselves. And then afterwards, that'll give you guys a little bit of a chance. I'll just kind of ask you like, hey, if you guys can like tell me a little bit more about your experience and your day to day, and if you guys created slides or even just like wanted to share anything about what your experience is, whether that's greater OT or pediatric specific, it's a good time. And it just gives everyone kind of like a general good background as to like who you are and what you do, or what you're going to do. And then after that, after I give you guys all a little bit of a chance to explain, then I'll turn it over to the crowd and I'll have them either unmute themselves to ask questions or throw questions in the chat. And then I'll be fielding those questions in the chat. So I'll read them aloud and then I'll give you guys a chance to respond. If there's anything that you're like, ooh, it's been a minute, because that's how I feel. It's been a minute since I've been to Rush. Annika's here, and Annika just graduated. So she knows all the current things about Rush. And then Bridget Hahn is here also to throw in some good resources and things in the chat too. So yeah, let me know if you get, do you guys have any questions?
Sierra is hopping on right now
Oh,
too.
hello, Sierra.
So just a huge thank you to all of you all. I'll be in kind of the background and I'll send you guys a CU letter, but I can't wait to hear about your experiences. These are kind of a highlight, kind of like when you have a patient come back and tell you about like what they're doing now. I'm like, oh my gosh, look at you guys, like out there doing the things. I want to be you. So thank you guys again for your time. And Daniela is done an excellent job with these, so I'll just kind of be low key. It looks like we had 20 folks register and quite a few folks in the meeting room, so we should have a good turnout.
Yeah, awesome. I was
And
gonna
I
say,
think,
let me just give Sierra a quick rundown. I think we're good to let him in, yeah?
yeah, and I think I made Bridget and Anna co-hosts just for, I couldn't figure out how, I can't remember how to do like screen sharing for all. But was anybody else planning a presentation or were you both? Bridget, no, then I'll just know. Does
Okay.
anybody have
Save
slides?
any slides.
That's totally fine.
You didn't have to. It was in case
No.
you did. Um, but yeah, I was just telling the rest of the group, thank you so much for doing this. Beginning, I'll just give a general intro about myself, then I'll turn it over to you guys. You guys can give a brief intro about yourselves, and then I'll turn it over to you guys to just kind of give a general, like, what you're doing day to day, what your general experience is. After you guys kind of give that summary, I'll turn it over to prospective students and current students to ask some questions. And then I'll read those questions aloud. They can either drop those in the chat or they can unmute themselves to ask aloud. If there's anything that you don't know, what's wonderful, as I said, Annika's here. She's a recent grad. She's wonderful. Brigid Hahn is here. She's a current professor, and all the community is here to help. So yeah, thank you guys so much. I really appreciate it. Okay. Any questions before we get started? Wonderful. Okay.
Okay, fabulous. I can let folks in then.
Yep. Hi, everyone. Welcome to our Rush Q&A session. I'm going to go ahead and just start with a brief introduction. My name is Daniela Ugalde. Um, I graduated with the class of 2024. It feels like just a hot minute ago, and I'm an admissions committee member as an alumni. And what's I love about doing these Q&A chats is not only connecting like current perspective and alumni members all together, but just really the spirit that this embodies. And again, getting everyone a little bit more familiar, not only about OT, but also Rush OTD as well. Just a little bit of background about why this started. This kind of came into the spirit, if you guys remember back in 2020. That is when I was applying to OT school, and I was finding it really difficult with the pandemic and in the midst of everything. And as a first gen student, to network and to get more shadowing opportunities and to really learn more and more about OT. I knew that I really liked it, but I wanted to kind of connect with more clinicians and more current students about like why OT. So what I ended up doing was I ended up just messaging a bunch of people on Facebook saying, hey, if you have 10 minutes and would like to FaceTime me to talk about OT, that would be great. Um, and that actually resulted in a ton of different opportunities for me to not only shadow different people once the pandemic grew, but also just opportunities to learn about why people were so passionate about OT. So once I decided to go to Rush, continue my education there, I was really thinking about as an alumni, like how I would give back to this wonderful organization for providing me the knowledge to be a good OT. And I really thought about how we could be more intentional. So this is kind of how this was birthed and created, was the want to kind of connect more people on the love of occupational therapy and why occupational therapy. And so we've kind of had a variety of different sessions monthly focused on different settings. And so today we're talking about outpatient pediatrics. So we have three wonderful alumni members who are coming back to talk to us about their experiences. So I will go ahead and let Brigid and Sierra and Anna introduce themselves. If you guys want to introduce yourselves by your name, your pronouns, when you graduated, and where you currently work now.
Awesome. Thanks so much, Daniela, for asking me to come back. Danielle and I were in the same graduating class of 2024. It does feel like it was just yesterday. Um, you guys have kind of caught me in a funny time. I just wrapped up a job and I'm starting a new one in a couple weeks. I worked at up until Friday, a primarily ABA clinic that also offers all services, including physical therapy, OT, speech, and feeding therapy. And the great story that I can give about Rush is that I was actually a student there during my placement at during my studies at Rush, and I loved it so much that I came back. And Rush really was instrumental in supporting me through that placement and helping me get it. So I'm so grateful for all my support team at Rush. And then next Monday, actually, I'm moving to the UK to London, and I'll be working in school-based practice there. So if any of you have any questions about trying to work abroad, because that's all I can answer right now, but I'd be happy to talk you through it and talk about the options that are there for us as OTs. But yeah, that's where I've been so far. And my pronouns are she, her.
I'm Sierra. I don't know if you guys can hear me. Um, but I graduated from the class of 2020. I actually graduated with Anna. We graduated right in that sweet spot time of COVID. So we were all on our capstone when that lovely thing happened, and we all graduated. And then yeah, kind of one of those things where you come out and you're like, am I allowed to be doing this? Am I allowed to be a clinician like this? And I think that COVID made that, 20 times worse with not having like an actual graduation and stuff. But apparently did work. I've been working at North Shore Pediatric Therapy for almost 6 years now. I started just in my general OT position, and then after about 4 years, made it into an assistant clinical director position, and then pretty quickly got pushed up into clinical director position. So um, I'm doing a lot more than I ever thought that I would be at this point. Running all of our teams, my center is also a similar space where we have ABA is mainly what we have. We have OT, PT, speech, mental health, and we also have neuropsych on our team as well. Um, yeah, so definitely have a lot of experience with that, like interdisciplinary, and some newfound experience with kind of climbing the ladder and figuring out, what else can I do besides just being OT, and what can I grow my position into, and how can I become more of a leader and a mentor in my space. So that's kind of what my current experience is right now. I still have a bit of a caseload. I still treat, I run group sessions, do a lot of like implementing new programs and things like that for my clinicians, but also have a lot more experience with management right now as well.
My name's Anna. Graduated with Sierra. My pronouns are she, her. And I work per diem at Seattle Children's Hospital inpatient units. And when I'm not doing that, I have my own private practice, where I specialize in, sorry, that's my dog. I specialize in a niche type of therapy called dynamic movement intervention. I'll I'll handle him in a second. But yeah, that's about me.
Awesome. Thank you all for introducing yourselves. Well, I'll go ahead and kind of just explain the formats of our Q&A. It's again a really nice opportunity for all of you to participate and ask your questions, whether again it be something very specific about pediatrics or even something broader about their rush experiences. What I'll go ahead and do is I'll start off with a very general question, and then afterwards, I'll invite you all to you can either unmute yourselves to ask your question or you can throw it in the chat and I will read it out loud for you. And then that'll give all of our wonderful clinicians an opportunity to answer any questions that you have. Does that sound good? Wonderful. Okay, so I'll go ahead and just start it off. If you guys can kind of just give me a rundown of like what does your day-to-day look like as a clinician? And I know that again, that might have looked different at the beginning of your career to what it looks like now. So I just kind of be curious as to what that might look like for you guys.
Sure, I can start us off. When I so working in a multidisciplinary clinic, which it sounds like Sierra might do something similar as well. We have kids that come to us for my company is called CST Academy. They also have classes, so we have preschool, pre-K, kindergarten. So we have kids that are coming to us from like 8 a.m. in the morning till 3 or 4, like a school day. And basically they'll be in ABA therapy and I will essentially like, I don't like the word pull out. I don't think it's exactly pull out services, but we'll take them to the gym for their OT session and I'll see them for 1 hour. So my mornings typically look like those multidisciplinary kiddos who are coming to us for all services. So that's ABA, PT, speech, class, if that's applicable to them. And then once that wraps up around like 3 or 4, typically the multidisciplinary kiddos go home. We have after school kiddos that come that are, so my multidisciplinary, I should say, are mostly kiddos with autism or autistic kiddos. And then my after school kiddos typically were general developmental delay, ADHD, got kind of that wider variety of diagnoses because they were coming after school for services. Just we typically separated them based on whether they were a multidisciplinary client or just an outpatient only client. So it kind of varied based on the day, but the bulk of my day was with the autistic learners, and then after school kind of varied on the day based on which learner I had. We also did a lot of co-treat sessions, which were some of my favorite things. So we do a lot of speech therapy co-treats was pretty common, a lot of feeding therapy because we could focus on utensil use, and primarily it can kind of depend on the clinic, but my clinic primarily the speech therapist did feeding, unless you were in an OT who was really interested in it, and then you could take on some of those clients. But so I did co-treats with them, and then we also had some PT co-treats and some ABA co-treats as well for those learners that it was appropriate for. So yeah, that's kind of what the day looked like. I typically worked from 8 to 5 or 9 to 6, depending on the day. Those were kind of our hours.
Yeah, my experience is very similar to that. We also have a similar kind of diagnosis range as well, where it's like most of our kids, and NSPT has like 11 centers in Illinois. We have a couple centers in Texas now. And so sometimes it varies depending on which center you're in, because a lot of times like the clientele will change. Like today I'm in our Deerfield center because like Bluff Center ran out of power, or not ran out, power went out yesterday. So we had to like move our whole clinic over to Deerfield and we're like, hey, move over, we're coming in. And it's a very different clientele. So it's very interesting because in Lake Bluff, we have a lot of really young littles. We'll get kids as early as 2 years old. And then usually in the evening, a very similar thing where our like autistic friends will go home and we bring in our more, we like our private clients that are again, same similar thing like ADHD, executive functioning, general developmental delay, those private clients that are coming from like after school that need services come in to see us. But over here in Deerfield, they have a lot of older clients throughout the whole day. So it's very interesting and it depends on the centers that you're in. But we have a very similar working time frame of like kids start as early as 8 and sometimes we go as late as 7 o'clock. If we have like later clients, usually you're working 11 to 7 if that's the case. But allowing us to service those clients that maybe don't qualify for school services. So that's really helpful that we get to help service those friends amongst all of our other ones. We also have kind of definitely for sure not as well put together, probably. We call it our Blossom Prep School program, where we are teaching kids and we have a couple different levels of kids. So we'll group them by sometimes age, but a lot of times like skill level. And so we do like push in, pull out services, similar thing. Sometimes I'm going in there, sometimes I'm pulling the kids out to do some things. Sometimes it's a mix of that kind of stuff. But treatment usually like 9 to 6 every day. I used to do 410s because I felt like I needed a day extra to do my report writing and things like that. Nowadays, I don't do as much treatment. I used to see like 34 kids a week, and now I see about 10. But my time is now filled with a lot more of administrative work. I'm pulling numbers for the company for all of my teams. I'm helping with caseloads and making sure that we're building those to the capacity we need to. I'm helping with all the stages of hiring. Anytime new programs get implemented, I'm helping collaborate on those teams with some of the other senior leadership members to kind of implement new clinical stuff. So definitely looks a little bit different these days, but a lot more administrative work and just providing like clinical support to my teams.
Um, my schedule is a little bit varied. Since I'm per diem at Seattle Children's Hospital, I'm more like part-time, so I have a consistent Mondays and Fridays. I'm typically there. Um, when I'm there, I work on all inpatient units, so all acute care, all inpatient rehab, and their cancer and blood disorder center. So usually I'll show up and they'll let me know which floor I'm on, and then I will chart review, and then I'll go see usually somewhere around 8 kids. Um, and some of that involves co-treats with SLPs or PTs. And that's always fun when that happens. And then I have a good amount of time during the day to chart review and document. And then when I am running my own private practice, which is consistently 3 days a week, and then 1 week a month, I do what's called an intensive, where a child comes for multiple hours of therapy per day, consecutively. Um, I'm usually treating between 5 to 8 kids, and I usually do that between the hours of 9 to 4. Each session is around an hour, and I treat alongside a PT who also specializes in dynamic movement intervention or DMI. Yeah, that's my day to day.
Awesome. Thank you all. It's amazing to see again what you all do in the general setting of outpatient pediatrics, and that it all looks a little bit different within your roles and just your day to day. It always makes me excited. Like it's that constant reminder that OT can look like a little bit different in each place, and that's what makes it special. Okay. So now this is the fun part where I get to open it up to all of y'all. Again, if you would like to ask a question, you can feel free to unmute yourselves and ask a general question to our clinicians, or if you would like, you can feel free to throw a question into the chat and I'd be more than happy to read it out loud for y'all. I'll give you guys a minute to think, or if anyone has a good question, I would love for you guys to start us off.
Anna, I have a question for you. Um, I'm curious if you could talk more about starting your own private practice. I've never really heard much about that, but I think it's super interesting.
Yeah, I think that's a great and really important question, and something we should be talking a little bit more about, especially because this is a tricky time in healthcare, and we um, are fighting against a lot of healthcare regulations and rules that are not always in our favor of what we want to do. And so to have the freedom to do that in your own private practice is uh, not something to ignore, but also there isn't a lot of resources or support out there for how to do it. So the more people you can connect with and um, ask these questions is important, especially if you're early on or a prospective OT. Um, I leaned on a lot of mentors and peers who had started their own practices and asked them the steps that they took. I wasn't really planning on opening my own private practice necessarily, but I had lived in Boston for 3 years. And during my time in Boston is when I found out about this specialty therapy called DMI. And I practiced it there for 1 year. And then when I moved from Boston to Seattle just about 2 years ago, I had some families reach out to me because I was on a registered providers list, and there weren't many providers in the state of Washington who were doing it. And because there was such a high interest and not enough providers to meet the need, I felt um, obligated to meet that need. And so I started by just doing home visits and figuring out how I was going to do my own documentation, what I would charge, um, like how to, all the paperwork, logistics, things like that. And that really came from other mentors and peers who were willing to share these things with me. And then, of course, lots of Googling. And then since then, I've expanded and have my own clinic space. But it definitely took some brainstorming, and it's still like such a work in progress because there just isn't like a course that tells you how to do it.
Thank you.
Anna, if I can ask a follow-up question to that. For your private practice, are you doing private pay or is it mostly insurance?
Great question. And any specifics you want to know about it, I'm a super open book because, like I said, I just feel like we need to be talking about this more and giving all of the information. Um, I had toyed between taking insurance or being private pay. And what I found is number one, it's really a long process to get credentialed with insurance systems. Not that it's not worthwhile, but it is a long process that could have delayed children receiving care that were really eager and adamant to start treatment. Um, and the other part of that is depending on what insurance systems you're credentialed with, you actually may not know how much you're going to be paid at any given time. It can really depend on so many factors that are out of your control. So, for those two reasons, I decided not to be credentialed with insurance and I am private pay. But um, all of the kids that I see are quite medically complex, and because of that, they've usually met their deductible pretty early on in the year. And typically, my kids get about 60 to 100% of reimbursement once I provide them with a super bill. So I'm giving them a super bill, and I use the same CPT code that we would use 97530 or 97112, depending on our treatment session. And then I'm doing a bill just like with their ICD code, number of units, my rate, things like that. And then that super bill is in the hands of the parent or caregiver who submits it to insurance for reimbursement, and then they receive at least partial or full reimbursement. And then the other part of that I tried to like justify ethically and make myself feel a little bit better about being a private pay practice is that I am really heavy on funding and grant resources and work really closely with lots of organizations that will provide funding for a child to receive intensive therapies. And we've had really good luck with that. So at least having some coverage just, gives me some peace of mind knowing that it's not all horrible.
Thank you so much. I appreciate that explanation. In your practice, are you the only practitioner or are you working with other people?
I am my own sole private practice and it's just me and I don't have any other employees, but I work alongside another PT who specializes in DMI as well, and we share the same clinic space. So we collaborate, but we don't like we're not we're two separate practices. But then let's say a child is coming for intensive therapy. They might see me for 1 hour, they might see her for another hour, which is also a nice loophole for insurance because insurance will usually reimburse 1 hour of OT and 1 hour of PT rather than 2 hours of the same discipline. So,
I
oh,
see. Okay, thank you.
yeah, yeah.
In the chat, while we're still on the same thought, we had the question of what makes it a super bill.
A super bill is just it lists the service that was provided, the rate, the like exactly what the session was, and then you submit it to your insurance for reimbursement. It's just like a not an invoice, but a statement of all of the sessions that have occurred.
Gotcha. Thank you. And then, okay, a question for all of y'all. Did all of you ladies know you wanted to start your careers in pediatrics, or did that opinion change when you started at Rush and got to see where more of your clinical experiences took you?
I personally actually had worked as an RBT at NSPT before I went and got into grad school. And so I knew that I had liked the pediatric population, but I was open to whatever else I would see, different settings and things like that. And then I feel like my career could have gone a very different way had we not graduated into the pandemic because I really, really, really enjoyed my Shirley Ryan Ability Lab day rehab placements. I really wanted to work there. And to be fair, my placement, my pediatric or my CI was half peds, half adults. So I did still like to see the peds part of it and work with the kids because I was teaching kids how to like pop wheelies and we were like baking stuff in the kitchen and it was a lot of fun. I really enjoyed it. But then of course, graduating into the pandemic, everybody was on a hiring freeze, especially Shirley Ryan Ability Lab. And so finding a job overall was a massive struggle because everyone was like, we had just been shut down. Like some places are still shut down for a little bit. Everyone was on those hiring freezes. And so I was kind of like trying to find anything that I could get. And I ended up being able to reconnect with somebody who had been my DCBA when I was in RBT before I went to school. And she was now the clinic director at the center and was like, we're looking for an OT. We have one leaving for maternity leave if you want to, pop into her spot. And I was like, I've been through too many interviews, too many rejections. Let's go for it. And then I've kind of just stayed here ever since. So I had always known that I liked peds, but I was really open to different experiences. But that's kind of how I ended up here. And I'm glad for all of it, of course. I like where I am. I like what I do. I like all my teams are great, but could have gone very differently.
I'll just tag on Sierra and say I did go into thinking I wanted to do peds, but of course I told everyone I had an open mind. And then I did one of my placements at where I work, and I just really fell in love with the autism population and felt like it really fit well with my personal attributes and what I could bring to a therapy session and my therapeutic use of self. So that's kind of where it clicked for me of like when that was my last week of that placement, I was like, this is what I could see myself doing every day for my life. And that was really reassuring to me. I forgot to mention I did do part of in early intervention and I did learn that for a little bit and learned very quickly that it wasn't the right setting for me personally and how my brain works. But it's an amazing area of practice as well. But it did take me trying that to realize I really like and value being in a clinic setting and being around my coworkers all day versus having that autonomy and individuality of EI that often comes with EI. So that took a little bit of working out for me at post grad too.
I came in wanting to go into peds. I had always wanted to, and everyone said, you'll change your mind. And so I really did try to keep an open mind, but I never changed my mind. And I don't even know what to talk to adults about, so had to stick with peds.
It's a great question though, and it does happen. I promise you it does. I definitely have worked with either other clinicians that oh, here comes my cat. This is my honorary little OT buddy. But it definitely does happen, but it's always exciting to see like what you come in with and what you come out with. Ella, did you want to go ahead and ask your question?
Yes, I wanted to ask about Rush's experience with hospitals and the clinical experience that can be provided, especially with pediatrics in that hospital or outpatient setting.
I did one of my rotations at Shirley Ryan, but I was an inpatient unit. Um, so I definitely think, and Danielle and Bridget would know, and Annika maybe better than I, but I actually also mentor a lot of our aspiring OTs who are RBTs at my current clinic, and I tell them like one of the first questions you should ask is exactly what you just asked, Ella, is like, what are your fieldwork partnerships? What does the variety look like of hospitals and peds? Because I will say there's some schools that I feel like have a certain niche sometimes with field work, and like they have a lot of opportunities for outpatient peds, but maybe not so much in the hospital setting. And it might be biased, but I think Rush has like a really, really, really sound selection of fieldwork sites that you could find something that you're interested in. There's lots of hospitals, and that could look like acute care, inpatient rehab, long-term care hospitals, stuff like that. So I do think that when people ask me that question at my current job, I tell them like, I think Rush has a really good repertoire of fieldwork sites that they can connect you with. And I think they're very collaborative in the sense of like you bring them a fieldwork site and are really willing to put in the work for creating the contract and helping them with that. They might be willing to help you set that up if you find one that's your dream placement, for example.
I can just quickly talk about it since I have just my name's Annika. I just graduated Rush, so I'm here to help support Daniela for questions like these because it has changed a little bit. But I can give you from my experience. I did one of my 12-week rotations at the Children's Hospital of Philadelphia. So I was able to get that experience. However, I had to move out of state for it. That was just the options that I was allowed at that time. Like Brigid said, there are many contracts. Some contracts that we have ask for students every other year to accommodate other schools. So every year, every contract looks different. So our fieldwork educator is really good at getting to know what the cohort that you're in wants and trying to advocate for those spots, but it's not always the case that they'll be in Chicago. So you kind of then get the opportunity to decide if that's something you really want to experience. Okay, maybe I have to move away for 3 months and go experience it. But like Bridget said, if there's an opportunity that you don't see on like a pre-existing site, then you're able to bring Dr. Hansen the site and she'll work with you to try to initiate a contract with that if it's something that they think Rush would be a good fit for. I will say though, like Bridget said, there are a lot of great outpatient clinics in the Chicagoland area that we have contracts with, as well as um, just like shadowing experiences. If you reach out to any OT around and are like, I'm a Rush student just interested in looking at that, they are happy to have you come and shadow them, as well as our PEDS professor, Dr. Popova, is very well connected in the Chicagoland area and very happy to use her network too to make sure that you get any shadowing experience that you want.
Thank you, Annika. I appreciate you. I'm so sorry I didn't introduce you earlier, but Annika is like the most amazing human being. She just graduated, so show her lots of love. Okay, our next question is someone who says, I'm currently debating MOT versus DOT. Do any of you guys have any insight of why you chose DOT or versus MOT? And if you guys have any involvement and participation in research, specifically, Anna, what does your research involvement look like?
When I was applying for schools, this would have been in 2017. There was the shift from master's to doctorate, and I just looked at every school. It didn't matter to me what degree it was, but just the school, the program that I felt was the best fit, that I could do in the least amount of time while still feeling like I could cover the ground that I wanted to cover, and the cheapest option. Those were the three factors that I had considered. I have to say that I'm not a huge fan of our profession going to the doctorate, because I think it excludes a lot of valuable professionals, and higher education is already not attainable for so many. So, that being said, I did really enjoy all of the research components that were included in the curriculum, and I'm really glad that I did it. That's just my general feeling on the shift. So if you are really interested in research and you love it and that's your jam, then of course the OTD is the most appropriate pathway. Um, but it, in my experience in the field, has not made a huge difference in salary, and it certainly doesn't make a difference in your clinical expertise as far as treatment. Some of the best OTs I know have their bachelor's degrees. Um, but having the research knowledge is certainly useful and bolsters your clinical approach. My involvement in research is varied. I am involved in some case studies right now, specifically with the type of therapy that I do with DMI. Um, and it's a perk to be able to use that part of my degree. Um, but yeah, that's my general consensus on it.
I also do, I know that there's generally like rules and regulations as well of if you want to be a professor that you have to have the same level degree as the like class that you would be teaching. And so if you have any interest in potentially, becoming an OT professor later, especially if we do, moving towards that requirement for everyone to have their doctorate, then if you ever wanted to do that, you would likely have to return. I do have one of my clinicians is currently getting her doctorate right now. She had her master's and she's in an online program and she really enjoys it. So there's obviously still a way to kind of do that later on if you were to decide, but if you kind of already know, my thoughts too is kind of like I do like peds. I like working with the kids, but this body will not be able to chase kids around for the rest of my life. And, I feel like the retirement age just keeps getting older and older and older. And I'm gonna have to work until I can, retire. So needing to kind of have a future plan for myself of like what else could I do. So definitely getting into my role of becoming more administrative and getting into the clinical director role has provided me an extra path. But another one was kind of like once I, become all knowing, which I know will never happen, there's a potential that I could become a professor then. And if I need to, slow down in my life and do something like that, then I have that option and I don't have to return to school because me and my ADHD are not good with school. So I'm not going to.
Thank you all. I appreciate it. Our next question is, what clinical experiences or electives during Rush had the biggest impact on preparing you for outpatient pediatrics?
Um, of course, something that's a component of a doctorate program, but really tailoring that to bolster my skills. Pediatric practice, I think, was like the most helpful. But obviously, Rush has dedicated classes. The balance of disabilities, one class is all about assessment and evaluation and report writing and things like that. And disabilities, developmental disabilities, two is more about the interventions. I was a TA in that class, and Virginia makes it very applicable. You're doing crafts, you're playing games, you're like doing all the activities you would do with a kid. So that I would say were the two most applicable courseworks for my practice. But I would say really tailoring my capstone to be in an area of interest of mine was what was most helpful for me personally entering postgrad.
Excellent. Okay. Our next question is, do you get the same amount of clinical hours in pediatrics as you do in acute care or neuro throughout your time at Rush?
So this one I think depends, and I don't know. It depends on what like school program you go to, but usually you get around like two levels of fieldwork experience. There's level one and level two. Um, for Rush, we did 2 level 1s and then we did 2 level 2s. I'm not sure if that's changed at all, but I know some other schools that I've heard of have done 3 level 1s, but level 1s are usually about 2 weeks long. Some schools will do them like 2, 3, maybe 4 weeks. It just gives you this nice little taste of a setting that maybe you're a little bit more apprehensive about. You're not really sure if this is something that would be up your alley, but you just want to be able to kind of observe and jump in a little bit and learn a lot more than maybe you would having done, observation hours somewhere. Because you usually do get kind of some responsibilities placed on you during that level 1 field work where maybe you will treat a couple clients or come up with the treatment plans for them. And then the level 2 experiences are usually 3 months long. Again, some programs will do them for a little bit longer than 3 months sometimes. It just depends on where, but we did 3 months. And so for the level 2s, you get the same amount of experience. So I had 1 3 month in my one level 2 was in at Shirley Ryan Ability Lab, and then one of them was in just an outpatient pediatric setting. So, and I chose those. You get to pick kind of what setting you would like to go into, and you get to pick which place you want to go to, and they obviously will do some matching with you. So you maybe don't always get the place you perfectly picked, but they will try to match you with that setting. So you can get a lot of experience in those same settings. So if you're between like acute care and pediatrics, you can have the same amount of time in both and really get to see what it's like to take over caseload in both those settings and figure out which one is maybe more meant for you. And then those level 1s are really just nice to kind of like dip your toe in and go, I don't know how I feel about this setting, but let me see what it's like. And then maybe you'll love it. And maybe, who knows, maybe you'll go into that later, or maybe you'll figure out a way to change your level 2 field works later.
Yeah, I will say, just like piggybacking off of that, like what was really beneficial, I think, is just like the humanization that Rush kind of creates about this process, about being able to have some autonomy in picking where your clinical hours are spent, right? Whether it's in those fieldwork opportunities or later in the doctoral capstone experience. My number one recommendation to all of you is just to be open and honest with your fieldwork educator and coordinator, letting them know, hey, this is the crosswords where I'm at. I really want to do acute care, but I also, deep down in my heart would love a school setting, or I'd love an outpatient ped setting. And having those conversations so that you're able to kind of, again, facilitate some of those opportunities too, because that's exactly the boat where I was in, where I was like, I think I really want to do schools, but I'm not sure about outpatient peds, and I'm open to seeing other things, but I also know that I have to do a physical disability setting. So what do you recommend for me? And it ended up working out really well in just the opportunities um, that I got through my field works, and then later on, even in deciding my doctoral capstone and kind of formulating that, right? It's always good to have those conversations, and luckily the faculty at Rush are really open to having those conversations. So it's really nice. Again, I think it humanizes the process a little bit more. Okay, our next question, it says for Brigid. In what ways does working in an ABA clinic differ from a traditional OT clinic, and how do the approaches differ?
Sure. So I would say working at an ABA clinic, I mean, I've never worked at I don't really know anything else. So, because I did my placement there, but I would say the biggest thing about our clinic in particular is the multidisciplinary collaboration. So, for example, I'm in constant communication with my learners, BCBAs, their speech therapists. Like, since we all work in the same company and we're almost all at the same clinic every day, I'm able to collaborate with them ongoing, no matter what. But we do have um, dedicated time every month to meet together to discuss each learner and any needs that come up. So I would say like a constant collaboration is like a big deal. And then I also will say like, since our company does primarily focus on ABA, well, I think that's just a fact. Sometimes we're brought, like the BCBAs are more of like the team leads sometimes, and they have the most communication with the parent. They meet with them weekly or monthly. And so sometimes we're like consulting with the BCBA, and the BCBA will be like, oh, this kid, I've noticed them mouthing a lot of things. Like, do you have any tips on what we could do? So sometimes it's like consulting with the BCBA and the RBTs and educating them on sensory needs and things. So I would say that might be one of the bigger differences, but is that sometimes you're in that kind of consult role, like even though it's not technically in your job description, you're educating the whole team on these certain needs, whether they're fine motor or sensory, and having them implemented across their whole day, such as a sensory diet or something.
Thank you. Our next question, I know that Sierra chimed in the chat, but I'll go ahead and ask it just in case there's anything that you guys want to add on. It says, does Rush tend to specialize towards peds as a specialty, or is it more of a wide-ranging program?
I just have one thing to add to what Sierra said. I think one thing that I was a little bit hesitant about Rush at first, but I am so grateful that they do, is that they require that one of your fieldwork placements, or correct me if this has changed, require that one of your fieldwork placements is in a physical disability setting. And I think it's just really essential as an occupational therapist, even though I was like so excited about peds, to have a holistic understanding of where we can practice and where we're able to meet our clients. So not every school does that. I've met OTs that did 2 school placements or 1 outpatient peds and 1 school placement. And that's not to say there's anything wrong with that, but I just really value that Rush really prioritized us graduating as general OTs, not as specialists, and that they ensured we were able to have that experience with the wide-ranging scope of our practice.
Yeah, I'll just add the curriculum highlights the physical disabilities, the neuro, the mental health, and the pediatrics all the same. So you'll have an evaluation course and an intervention course for all of those, and then documentation and other courses as well. But it is not like heavily peds. They, like that it's been said, that they do a good job at making sure you're well-rounded.
Excellent. I know we kind of we touched on this, but if there's anything else anyone wants to add, our next question is, could someone describe your experience in neuro rotations and neuro placements?
My physical disabilities placement was at Shirley Ryan Inpatient Rehab, and I was on the float team there. So I didn't know where I would be. I was told you're going to go to Shirley Ryan. I was like, cool. And then once you get your supervisor, you kind of find out where you'll be. So my supervisor was on the float team, so we got to go to the stroke floors, traumatic brain injury. They also have a floor that's like general musculoskeletal conditions, from my understanding. And so that obviously looked very different than the outpatient peds I do daily. And I kind of empathize with Anna when she was like, I don't know how to talk to adults. I kind of felt that way when I was there, but it was very educational and very enlightening to learn more about all of the different conditions and the different types of therapeutic activity and exercise we can do with all those clients. If you have any more specific questions, I'd be happy to answer those as well. But I was able to see traumatic brain injury, strokes, cancer patients, heart transplants, liver transplants. We also did wheelchair skills with spinal cord patients and things like that. I know Sierra probably got a lot of experience with that in day rehab too. So it was really, really cool. And a lot of our professors still have connections at Shirley Ryan or used to work there. And so it's very cool to kind of continue to build a Rush name within that hospital as well.
And I did I was trying to remember, but I did a level 1 experience at a place called Midwest Brain Injury Clubhouse for adults who had recovered from brain injury. And then I did a level 2 field work at Rush Inpatient Rehabilitation, and it was super incredible. They almost got me there to work with adults. I thought about it for a second, but kids are really just small adults. And I do a lot of neuro in my practice. So it was all really helpful.
Thank you all. Again, Sierra, you're on it on the chat, but I'll ask this question just again if there's any additional insight. And I also really like this question because not only does it force us to think back think back in time, which already I think this Q&A session does, but also like go even further back, right, into like what are your roots? What got you even started in OT? But they ask which undergraduate courses or experiences did you find most valuable in preparing you for your time in OT school or your career?
I responded in the chat too, but I did public health, and I feel like like it just gave both hard and soft sciences, and I also minored in psych, like Sierra said. I feel like psych is a really common one for OT students, but I feel like at Rush too, we get a lot of people who have been working for a couple years in like business or like something completely unrelated, and you can always come back and like readjust your skills because OTs are jack of all trades and all skills are beneficial for OT. So I feel like no matter what you majored in undergrad, it will be applicable in your career.
Excellent. Okay, thank you both. Next one is outside of classes, are there any extracurriculars you guys were a part of during your time at Rush, or what options do you know of? Did you know of that were available if you didn't participate in any?
I was in one at when I was at Rush, and it's called Neurodiversity Allies, and it's a really great program. If any of you do end up at Rush, it is a program that's run by med students, speech students, and OTs, and really anyone that goes to school at Rush. But those are typically the people who lead it. And what it is anyone who's staying at Rush Hospital, I believe mostly the acute care side, who has an intellectual or developmental disability, their nurse can refer them to neurodiversity allies, and they come to us and we send a volunteer to go hang out with them for like half an hour and try to make their stay at Rush more comfortable or engaging. So that was like a really great experience to have, especially if you're interested in like combining that passion for developmental disabilities and inpatient care. It was really cool.
I'll give a quick shout out. At my time, I was in Rhoda, particularly an organization created to seek I would say more equity and racial justice in the OT system. It was really important to me, being a first gen Latina OT, to find those opportunities to seek more diversity, not only within our field, but within OT education. So that was a little bit of our time, just like advocating for different events, different sharing of knowledge, different recommendations to our professors and faculty about what changes we would like to see in our OT education, as well as changes in the field of OT, so that not only we're able to serve a very specific set of clients, but a wide set of clients. So I really enjoyed that. That gave me a lot of purpose, not only within my heart, but just also for the general community as well. Um, we have a few more minutes. We're going to try to get through as many of these questions as we can, and I appreciate clinicians for responding in the chat. I'll keep going through the questions though. What has surprised you most about working in pediatrics compared to what you learn in school or fieldwork?
I think a really big one is insurance. Mainly, like, again, I'm not sure if there has any curriculum at school has changed for Rush. It's really hard because a lot of the students that come to Rush, like my cohort, we had people coming from like California, and a bunch of other states and things like that. And so insurance is different, one by state, but then two by setting, and all of that kind of stuff. So we didn't really learn about it in school besides very basic information of like documentation and how you write like your daily notes and how you can do some like report writing stuff that would help you with insurance purposes. But other than that, they don't really teach you. And I felt like personally, my experience on my field works was my CIs always left insurance out because they didn't know what setting I was going to go work into. They didn't know if I was going to go to a different state, all of that kind of stuff. And they just didn't really teach you anything about it at all. And so I think that's been a really big piece is learning about what are the limitations. I've learned so much about insurance, about like hard max limitations that clients will have, despite how much you think that that kid needs services and how many letters of medical necessity you write and how many peer reviews you have with insurance, insurance is just like, nope, we've made the rules. You got to stick to them. And so that has been really big because we all go into, I assume, I think, we all go into OT because we care. We care about patients, clients, we care about people. We want to help them. We want to help them, gain skills, relearn skills, accommodate all of that kind of stuff. And insurance is the one thing that immediately knocks you down and goes, yeah, we don't really care what your intentions are. We don't care how much you're passionate about this and how much you want to help people. We don't want to spend money on it, so we're not going to. And so trying to learn about insurance and ways to get around it and just kind of like some of that moral piece that you have inside of you, and then fighting against the system of insurance that does not have much morals to it. That has been a really big thing that has just been an on-the-job training because it really does just depend on what setting you're in, what state you're in, all of those kind of things. But I would say insurance is one of the biggest ones for me that like nothing could have prepared me for. And if you go to a workplace and you have really good supports, people will walk you through exactly what you have to do. And so you don't have to worry about being on your own or anything like that. But I just didn't know what it would be like to have to work with insurance when I was in school. I was just like, this is so much fun. I get to play all day. I get to do all these things. And then it was like, yeah, now go write all these reports and write these daily notes. And then, when they deny it, send it back, you got to fight for it again. And that was like, oh, I really like this part. I like the playing part. I'll keep up with that.
Thank you, thank you. Our next question is, would it be possible to discuss any of the opportunities that are more involved with the Rush hospital system?
I know I mentioned the Neurodiversity Allies, which is a great way to get involved. And I know that our practicums are, a lot of them are in the Rush hospital system. So I know we have acute care, we have inpatient rehab. There's also Midwest Orthopedics at Rush, which is part of the Rush system, which is primarily like outpatient arms and hands, from my understanding. And then I would say like, those are like what I'm aware of. And then, but I also feel like Rush is just it's a teaching institution. So anytime like a student might come up with an idea or want to shadow or get involved more in the hospital, I'm sure they'd be open to you reaching out. And I know like a lot of my friends who did placements at Rush ended up being hired at Rush, and like it's a very well-known place to work as an OT as well as to be educated as a student. So that's my knowledge. But I know we have a lot of connection within the hospital because one nice thing about Rush too is that we're going to school literally at the hospital. So you're constantly in there, the Panera's in there, and like you're walk through there every day. So it does feel like you're kind of like pretty well integrated. But I'm sure there's more ways than I'm aware of to get involved as well.
Yeah, one other thing to note too is just the clinicians themselves. So we have OTs that come and help us with transfer labs. So they come to us to teach us as well, which is nice because even though our professors are also practicing clinicians, these clinicians are at the bedside every day. And then, like Brigid said, there's a bunch more. They call it RSIP, and I put a link in the chat too. But a lot of those clubs offer you the opportunity to go into the hospital and volunteer so that you have more exposure if that's something that you want to look into.
Excellent. We have about 2 more minutes. I know that we have a handful of questions left. I was going to say that I'm happy to stay on the chat a little bit longer and answer some of those questions to the best of my ability. I'm a school-based OT, so my perspective might be a little bit different, but I'm hoping I can answer some of those general questions. Or clinicians, if you have time, that would be wonderful. But I'm going to go ahead and wrap it up just because we only have a minute left, and I want to thank Anna, Sierra, and Bridget for their time. Thank you so, so much for sharing your experiences, your wealth of knowledge, and again, just showing what it's like to be exemplary clinicians in the field. So thank you all so much, and thank you to everyone in the chat for again, just being wonderful participants, having some great questions, and really feeling our discussions. I know that Annika dropped some links below, but we do this typically monthly for a few months in the year. So if you're interested in maybe learning what some neuro OTs have to see, or what acute rehab OTs have to say, or even some that are in academics or other fields, not only do we have other Q&A sessions that we have filmed previously before, but we have more that are upcoming. So join us next month too if you're interested. Thank you, everyone. I will hang out for a little bit longer. And again, clinicians, you're welcome to if you want to as well. But otherwise, have a wonderful evening. Thank you, everyone.
Thank you.
Wonderful. Okay, Alexis, I see that you had one question about what are the major differences between working in early intervention and outpatient pediatrics? How is it different to work with the younger kids versus the older ones?
Yeah, in the chat, I mentioned like EI is often home and daycare setting. So it just kind of naturally changes like the materials and the equipment and things like that that you have access to. If you were to be in a clinic setting, you're going to have access to more things like swing systems, playground systems, some of that kind of stuff to work on, like, different types of like coordination. You'll have potentially like more play spaces as well. Like a lot of ours have pretend play kitchens and things like that. And with EI, it just really depends on what the family has within the home. And so, especially with EI, you can find yourself in somebody's home that maybe has a higher income and maybe they have every toy in the world for the kids. And then you can utilize all of those materials. But you'll also have some of those more lower income families that maybe don't have access to that stuff. And so as a clinician, you'll oftentimes bring your own materials as much as you can, but you're not probably going to be lugging in a little, um, play system into each, client's house then. So it just changes what you have available to you. The great thing about OT is that we are all so creative and we learn so much about being creative that you can still make it a wonderful experience when you have less that you're able to like materials and things like that that you're able to use. And you usually are then traveling throughout your day. You're driving, to house, whereas in a clinic setting, you usually get to be in one place at least for the day. I do have a lot of clinicians that split between our centers, so they will do some traveling day to day, but for the full day, usually they're in one place. And then you just get to have access to different kinds of materials and swings and equipment and things like that. But there are people who do EI that, get those sprinter vans and they turn them into a mobile space, and then you can have access to all that stuff. That would be a dream. I think that would be really fun to do. But it's a lot of just kind of what materials you have access to in that kind of setting.
Thank you, Sarah. And I know Bridget dropped some good info too about not only the environment, how that changes, but also the funding for EI as well, which does make a little bit of a difference too of how you provide your treatment. Excellent. Uh, I'm gonna move on to your question, Sarah. Thank you, Alexis. I appreciate it. If you have more, please stay on. Again, you have good questions. Sarah said, did you dislike any certain areas when you first started observing OTs for your application? I would be honest, I would say yes. Ironically, it might have been outpatient pediatrics for me. That's where I got a lot of my shadowing experience in. But not to say that I didn't give it another chance because that was one of my field works again when I did go to grad school. So it was good. It was good to come at it with a different experience and a different level and a different lens. And for me, it confirmed that it just wasn't the place for me, but that's okay. And I think that, again, if you're able to kind of just like highlight some of the cores, like some of the core values and ideas I think that OT is trying to get at, it's still a valuable experience. And again, it's still valuable because now you know, like, hey, that wasn't for me, or I really like this thing about it, but I didn't like that thing about it. So yeah, it's not just you. I don't know. Did you guys have any experiences like that as well?
I feel like for observations, the nice thing was that you could ask to observe somewhere and you could see it for a day and then go, yeah, no, I'm good. I'll get my hours somewhere else. Um, it more so for me came in field work. My level one, I was supposed to be in inpatient rehab, and like a week before they canceled it and switched me to acute care. And I was like, that is the one setting I know I do not want to be in. And like there are too many lines. I feel like my memory is too bad to know exactly which lines I need to be managing, and I like cannot be responsible for injuring somebody in acute care. I made it through the 2 weeks, barely. I cried once, but I made it. Um, but I feel like that was more of a space where I kind of was just like, oh yeah, no, this does confirm this is not the spot for me. But it was also like it's a 2 week commitment. You could do anything for 2 weeks, and your CI is usually still very much over you, watching everything that you're doing. So I felt very comfortable learning in that space, but it did give me that confirmation of like, yeah, that's not for me. I'm gonna stick to outpatient, whatever I decide to do.
I will say too, using all of it as a learning opportunity. So, like Daniela said, of still giving things a try even after you observe them, because most likely your observation hours are going to be with only one or two OTs, and maybe you just don't like the way they run their sessions, but you actually like that setting. So, continuing to have an open mind, but then also, as Sierra was saying in fieldworks, using it as you're going to have to study and learn everything for your board exam. So even if you don't like it, becoming competent in it is kind of your end goal for field work. So keep an open mind.
Thank you both. Appreciate it. Any other questions I can help answer for y'all?
I just have one more.
Sure.
I was wondering if you had any advice for people applying for the cycle, because I'm like trying to get all my things together and like what's like a good way to like stay calm and get it done.
Yeah, yeah. Give yourself a lot of grace. It's a large application with a lot of moving parts to it, I would say. I think my biggest thing as someone that has read applications for a few years now, um, is to, in your personal statement, like really talk about like the opportunities that make you very unique. I think that sometimes we get really caught up in like some of the clinical experiences that we have, which are valuable, but also talking about maybe some of those like non-traditional experiences that you have, and even just listing them in your application as well. Like some people will be like, I was a waitress at Denny's for 5 years. Why does that matter in OT? It does matter in OT. You learn a lot of different skills in that job that you need to apply within your work every day. Even if they would be some of the more non-traditional things. So like talk about that and talk about how, that impacted, and then other things that like helped you find OT. Like they're all part of your journey. They're all important details to include in part of it. So that's one thing I think that I would note on like an application, is talking about all the different things that you have done. Um, whether that's a job, whether that's volunteering, whether that is a class that you feel like has really stuck out to you in an experience. Um, and agreed with Brigid, OTCast has only been open for a hot sec, so I'm very impressed. But give yourself time to like complete, like I would say, never rush like an application for the sake of just like rushing it and being done with it. Like make sure that you're have all the things that you want part of it that really say like this is why Alexis is a unique individual and this is why she wants to be an OT, not why, generally the public wants to be an OT. So yeah, I think that's my biggest advice. And again, just kind of like working, that's the way I work best, is just working it in chunks. It's really difficult for me to sit down and finish a whole task. Even if it's like, yep, I completed the intro page and I wrote down where my address is. If that's the way you need to chunk it, that's the way you need to chunk it too. And again, like in the interview portion too, that's when you get to share a lot more um about some of like those other individual pieces too. But yeah, it's a big beast. Anything else, y'all? Sorry, I rambled for a hot sec. I enjoy the admissions process as a whole. It's very fascinating to me.
I was just gonna say, as another person who reads a lot of applications, make sure that you in OTCAS, you have the opportunity to write things about your experiences. So the experience portion is really just you putting in your resume, but then there's a blurb. Please fill out what you did, how long you did it, like what skills you did, because that helps us get a fuller picture of who you are. And if we don't know that, we have to like look at you not knowing that. Whereas if you maybe were a teacher of a classroom of 30 kids, but just put teacher, we don't know what your day to day looked like. And so giving those details is really helpful and something that I think people often overlook. So, like Daniela said, just sitting down for 15 minutes and just typing one experience and being done for the day doing that. But giving us detail will help us be able to kind of see you as a person through paper, if that makes sense.
Wonderful. Okay. Sarah, did you have anything? No problem, Alexis. Have a great night. Okay, sounds good. Well, thank you both. I appreciate it. And again, Annika, Sierra, Bridget, Anna, thank you or Anna, sorry. Thank you all so much for staying on, for all of your work, for all the insight that you've had. I really, really appreciate it. Bridget Hahn will be in contact for those CEUs that you guys get for this. So thank you, thank you. And just appreciate you all so much. You guys have a wealth of knowledge and just opportunities that have come your way. So I'm very happy for all of you. And thank you so much for spending this hour and 10 with us. Have a good night, y'all.